Hi everyone, my name's Gary Royle. I'm from University College London. My talk today is predicting response to cancer treatment using computational techniques. Firstly, I want to talk a little bit about some of the challenges we face in cancer research. One is a matter of scale. A fact often quoted is that approximately half of people born in the last 50 years will be diagnosed with cancer at some stage in their lifetime. Also, we are anticipating an increase in cancer incidence and therefore cancer deaths over the coming years, with a greater increase seen in the less developed countries. The second challenge is the range of types of cancer that we need to treat. We see here from this Globocam plot of the various types of common cancers and the scale of it. And each of these cancers respond differently to treatment and have different effects on the patient. And so we need to take them all individually. It also shows us that last year, there were 20 million new cases worldwide and 10 million deaths as a direct result of cancer. How is cancer research improving things? This data from Cancer Research UK shows the change in survival over a 40-year period from 1970 to 2010. If we look at all cancers, survival is improved from 25 to 50%. And then looking at the various common cancers, we see some of them have fared well. For example, prostate has seen a dramatic increase in survival. Others down towards the bottom of this table, for example, brain, lung, and some of the gastrointestinal cancers have fared much worse, and survival remains low today. The third challenge I want to highlight in this talk is the difference geographically. So we take two common cancers, prostate and breast, and a common childhood cancer, leukemia, and we look at the change in survival over 5 years between certain developed countries and developing countries. Differences can be accounted for a number of reasons. For example, access to state-of-the-art healthcare, awareness of cancer symptoms, and also ethnic, lifestyle, environmental differences. So there's other challenges as well that we face. And so the question I'm asking here is, how can data contribute to cancer research and improve outcomes? Let's take the different types of data seen within these ovals. What we know is information about the type of treatment, so the clinical technique. We know details about the patient from their patient records and their patient history and their family history. We have information from other trials and from the literature about previous studies. And we collect tissue, blood, images, pathology for each individual patient. Combine that with expertise of the clinician and their experience in treating this type of cancer and these types of patients, and also what we know about this particular cohort. We can take all of that information and feed it into a computational analytical method. We can then use this to help the clinician make a decision. It's not replacing the clinician, it's giving them extra tools. And this will generate a clinical outcome, which with all of this information, we hypothesize that the outcome should gradually improve with time. And then we can reverse translate and iteratively feed back the clinical outcomes that we get as another input. And gradually, this will start to improve the clinical outcome. We can then connect with other hospitals worldwide and build up this database and this knowledge base. So looking at predictive modelling, what role could it have in the clinical decision process? And there's many. I list a few of them here. For example, we can calculate performance metrics for cancer treatment. For example, survival or progression-free survival. We can start to stratify and even personalize treatment by categorizing the patients and understanding how well we think they will respond. We can also start to inform discovery research by contributing to an understanding of mechanisms of how the patients respond individually to the various therapies available. And we could even start to contribute to the design of clinical trials by predicting how we think the patients might respond. I want to talk a little bit about some of the work we've been doing at University College London. We've built a deep learning platform for predicting cancer outcomes. The blue box on the left shows the types of inputs that we can have. For example, medical records that contain lots of information about the patient, digital data, for example, MR, CT, nuclear med images, pathology scans, and then biological data, blood tests, tissue biopsy, genomics, and various analytical techniques. We've adopted a hybrid neural network approach, for example, using multi-layer perceptrons, recurrent neural networks, convolutional neural networks, where different ones have benefits in different outcomes and different endpoints. And looking at what we can achieve detailed information on a patient-by-patient basis to anticipate survival, progression, likely response to treatment. And then we can group together to look at an overall cohort and look at overall survival or progression-free survival or other major outcome metrics. Looking at how we've applied it, I want to cover 5 examples. The first one is looking at predicting survival probability of colorectal cancer patients. Colorectal cancer is a very common disease worldwide and with poor outcomes. What we do at the moment is that clinicians estimate survival for individual patients based on experience, cases they've seen before, and on the general knowledge of the field. Each clinician can only know a limited amount, and so we hope to enhance that knowledge by providing them outputs from a model. Overall aims, so use neural network-based approach to predict cancer outcomes, and then include different types of information about the patient in a multivariable approach, and look at different outputs that we might want to achieve. For example, things that are very specific to this particular cohort and the treatment that they receive. What this data is showing as an example of the output is for patients where we're looking at the dashed red line and where the blue histogram bars cross. And that tells us where we anticipate the progression-free survival point to be for this particular patient. Retrospective analysis told us for this patient it was 18 months, which our prediction comes close to predicting. We look at other patients, and again, we can see that we get close to an actual prediction. So far where we are, on the limited number of patients we've looked at, we have an accuracy of just over 85%. And as many of you all know, in machine learning, deep learning approaches, we can gradually refine that number and improve accuracy up to an inherent limit. by putting more data in and more information so that the model can learn. A second example refers to pathology and what we can do to improve pathological information. As many will know, pathology informs cancer grading and risk assessment. It is labour intensive and can sometimes, if information is unclear, require additional scans or additional staining. We also have the potential, as much of the literature recently is showing, of incorporating biological analyses to improve diagnostic and predictive capability, for example, genomics. Overall, what we are planning to achieve in this project is initially looking at characterization of the tissue type, and then going on to see, can we extract more detailed diagnostic information without the need for follow-up scans? And how do we incorporate genomics information? And what does it add in terms of diagnostic capability and predictive capability? Looking at the first point, here we've characterized some colorectal tissue scans. So you'll see the original tissue shown in this pink wash, and then our convolutional neural network classification, where we have managed to identify the different tissue types seen by this color map and the table on the right. A third example is looking at, again, predicting survival, in this time for non-small cell lung cancer patients. Lung cancer is the most common cancer worldwide and has very poor outcomes. What we've done in this case is we've taken a data source, so a phase 3 clinical trial. In this trial, they were comparing different treatment regimens. For example, high and low dose radiation in combination with a chemo drug, or just radiation alone in a high or low dose. We've taken our multivariable input approach, in this case, looking at pre-treatment CT scans, treatment information, patient information, and so on, all the information that was available through this trial. And here we see the progression-free survival curves for the different study arms and overall survival curves from the trial. And we've made our own predictions and compared with the trial data. Where we are at the moment, we have statistically significant accuracy of just under 0.7. But with more data, we would expect this again to gradually rise. A fourth example, looking not at survival in this case, but anatomical changes that we would anticipate the patient to have during radiation therapy. As they change over a course of radiation therapy, if you don't update the treatment plan, then you gradually reduce the quality of the treatment the patient's getting. In this case, we've been looking at head and neck cancers, and we look at different types of changes. So, for example, on the left here, we see anatomical changes. So the patient is changing to reflect the day-to-day change over the course of their treatment. Treatment will happen over a few weeks and 5 days per week. And the color wash overlaid is the radiation dose map, going from the dark red of a higher dose down to the blue and purple of the lower dose. And you can see as the anatomy changes, the overlaid color change will slightly change. Looking on the right, we can see positional variations or slight movement. And this was simply modeled by a proton beam in this case, coming in from the right and looking at the dose map with day-to-day or even during the treatment changes. So the aims of this project is build these anatomical models to predict changes in treatment, and then use those predictions to help create a better treatment plan, a more optimal treatment plan at the outset. How did we do it? So we took the high quality CT image that is always taken prior to the radiation therapy treatment. And then we collected this for a large number of patients and made an average patient. Then we can take a map of an individual patient and compare and look at changes. How does one compare to the other? And essentially, what we're doing here is taking the assumption that an average patient over a course of treatment, this particular type of treatment in this particular location of cancer, will experience a particular weight loss, largely through the radiation causing it difficult for them to eat in some cases. And we assume, let's take the average weight loss over time and assume that individual patients will follow a similar pattern, but from their own individual starting point. And so we can make a prediction for how we anticipate each patient will change throughout the weeks of treatment. And therefore we can do various things. We can either anticipate that and have a new treatment plan ready based on how we think they will look at that time point. We'd obviously validate and verify. Or you can change the original treatment plan to compensate for those changes throughout. Some results that we have just to highlight. So this is a radiation dose map overlaid onto the grayscale CT scan, and the arrows highlight how we anticipate the volumes to change over time. And therefore we could modify the dose accordingly at the time. The final example I want to cover is, again, looking at radiotherapy, in this case for brain, and looking at, can we personalize the dose that that patient receives? So our motivation for this, so there's no guidelines that state the exact prescription dose. And the current dose levels have been around for a long time. It doesn't mean they're wrong. It just means it's always good to review clinically. And there's a wide range of commonly delivered doses. So what we did in this case is we considered optimizing the prescription dose based on how we know that the patient will likely develop and respond. So this here is what's known as a dose volume histogram, which is commonly used in radiotherapy to show effectively the dose to individual organs. And our optimization method found in this particular patient, so this is an individual case, that we could have potentially benefited from increasing the dose by about 8.5 gray. All of these examples I've shown are work in progress. Nothing is finalized and no clinical decisions are made on the basis of a predictive model alone, but it gives an extra tool available to the responsible clinician, and they can use that, refer to that, and couple that with the other information that they have available. Thank you for listening. I appreciate your time. And I also want to thank all of the people, the collaborators and the funders that have made all of this work possible. Thanks very much.